Well, so now I'm going to introduce our speaker by sharing her microphone. So I have the distinct pleasure of introducing Dr. Danielle Sanchez. Dr. Sanchez completed her pharmacy school training at the University of Illinois at Chicago. She also did her first year of pharmacy practice residency at that hospital as well, and then just completed an ID pharmacy residency at Advocate Christ Medical Center and Advocate Children's Hospital in Oak Lawn, Illinois. And so then she got tired of the snow and she decided to move to Florida. Lucky for us. So she is now, as her slide says, the pharmacist coordinator for infectious disease. So she is our second ID pharmacist at the hospital, which we are super grateful for. And one of her research interests is in the accuracy of MRSA colonization detection methods to predict MRSA skin and soft tissue infections. And so she's done some research in that, and she's also really interested in how it can benefit our antimicrobial stewardship efforts. So that's what she's going to talk about tonight. And so without further ado, Dr. Sanchez.
Thank you very much. This one is working okay?
That one's working.
Okay, perfect. Thank you so much, Dr. McCarter. I'm so happy to be here. Yeah, my dad texted me this morning. It's -12 degrees in Chicago, so I'm very happy to be here. So without further ado, I'll go ahead and get started. As Dr. McCarter said, my name is Danielle Sanchez, and I will be presenting my CE presentation today titled Beyond the Swab and Past the Lab, the Clinical Impact of MRSA Screening. I have no disclosures. Nobody is paying me to be here at this time. Learning objectives. I have a few for you all today. One is to, the font got a little jammed there, but that says to explain the purpose and process of collecting methicillin-resistant Staphylococcus aureus or MRSA surveillance screen on patients, to define the term sensitivity, specificity, positive predictive value, or as I'll refer to going forward as PPV, and negative predictive value, or NPV, as they pertain to clinical interpretation of laboratory tests, and to review literature that supports the clinical use of this MRSA surveillance test in antimicrobial stewardship efforts. So to start off with some background, let's start off by talking about MRSA. Yep, here we go. Just make sure my... Just want to make sure my accurate pointer is here. Okay. So as we all know, as healthcare workers, we've all heard of Staphylococcus aureus or Staph aureus, simply because of how prevalent it is. It's very common in human flora, essentially ubiquitous, living amongst all of us. It is one of the few organisms that's part of our flora that can be pathogenic and can cause infections of many kinds that we see both in the community and in the hospital setting. MRSA is a classification of Staph aureus, which is defined by its resistance to methicillin or oxacillin. And this strain was first discovered in the 1960s. And since then, it has become endemic in a variety of different healthcare settings across countries around the world. MRSA has been recently reported to be the cause of 42 to 56% of hospital-acquired infections. Not only is it very prevalent, but it is associated with a significant mortality risk when the infection is invasive. It has been reported that MRSA bacteremia causes death in a range anywhere from 15 to 60% of cases, which can be pretty scary, and in about 1/3 of MRSA endocarditis cases. It's also been reported that 50 to 60% of all patients who are admitted to the hospital will receive one antibiotic. And if we can guess which one that is, it's my favorite and least favorite, vancomycin. So you might be wondering who is at risk of infection because it is very ubiquitous. So who should we worry about with MRSA infections? There have been multiple studies that have demonstrated a past colonization or past infection increases the risk of future infection. Those who have been recently admitted inpatient, have had surgeries or medical devices implanted, pretty much anyone who's had a break in their skin at some point are at risk of MRSA, especially in a hospital setting where it is very prevalent. those who have been recently exposed to antibiotics, especially broad spectrum antibiotics, are more likely to have a resistant strain of staph. Some other risk factors are due to the diminished ability to fight off the infection. So this would include patients with HIV, particularly those with a low CD4 count, those on immunosuppressive agents, for example. So now, one of the previously mentioned risks was colonization of MRSA. Although staph is a very common member of our skin, not everyone harbors the methicillin-resistant strain. The CDC reports that approximately 1 in 3 people in the United States are colonizers of Staph aureus within their nose, and about 5% of patients within US hospitals carry MRSA in their nose or on their skin. In many infection control guidelines, swab-based screening is recommended to identify those who are asymptomatic carriers of multi-drug resistant organisms, MRSA being one of them. And the NARES is the typical site for colonization testing because it's not only the principal reservoir, but most practical site for screening in clinical practice as well. And when it comes to surveillance screening, there are multiple approaches, variable methodologies, making the process pretty difficult to standardize. So infection prevention guidelines actually lack clear guidance on the swab material to use when it comes to actually swabbing the nose, whether it's polyurethane, foam, flocked nylon, can all have a difference on the sensitivity of the test. The laboratory technique, so whether this is a normal culture, depending on if it is molecular techniques or even selective agar, can make a difference in the detection rate. Not only related to sensitivities, the frequency of screening is variable across different institutions and units. So some hospitals, for example, the VA or Veterans Affairs hospitals, they require MRSA screening upon patient admission. Whereas our institution, well, my institution, UF Health, there are guidelines on particular units such as the NICU or the ICU, where it is mandated that these patients are screened for MRSA. So technically not everyone needs to be screened. And then also, of course, the patient population to screen is variable depending on risks. So now we'll talk about the MRSA PCR screen assay itself. So the assay is a qualitative test, meaning it's not going to tell you how much MRSA DNA is in your nose, but it simply determines, are they colonized with MRSA, yes or no? And it does this by amplifying the MRSA-specific DNA, and it utilizes real-time PCR and detection of amplified DNA via fluorogenic target-specific hybridization. And there are different colonization tests that determine the presence of Staph aureus, both methicillin sensitive and resistant, but this test will only detect for MRSA. It won't detect for coagulase negative staph or MSSA. It's very convenient in the sense that these rapid tests, such as the real-time PCRs, are complete within about an hour, up to 80 minutes. But accounting for time required for shipment and reporting of results, where luckily our lab is directly adjacent to the hospital lobby. The final report is available. I've never seen it later than 24 hours. I haven't seen it reported any longer than 2 hours, I should say, personally, from what I've seen so far, compared to a culture, which can take up to 3 days. Aside from timing, the PCRs are more sensitive compared to the cultures. So the PCRs actually have a sensitivity of 92.5% compared to a reported 86.9% in cultures. So for all of these reasons, the PCR is more commonly used today. And to go over the process of collection, I'm sure if any of you have done the screening, you're pretty familiar with what it requires. So first we grab our special red cap swab. And this is directly taken from the UF Health laboratory guidelines. So it could vary depending on institution and practice. Step 2 is to insert the dry swab into the nostril, rotate it about 3 seconds, applying pressure outside of the nose, doing the same exact thing on the other nostril, using the same swab, putting that swab right back in the tube, and making sure the label is appropriately labeled with the date and time, collector, etc. So pretty easy. It is important, though, that the specimen collection, handling, and storage is essential to ensure accurate results. There is a maximum allowable transport time, 24 hours, although as mentioned, never really takes that long. This test is available daily and the turnaround time is the same day. But proper specimen collection, handling, storage, and technique is essential because of the possibility of false negatives and false positives. So for example, a false negative can occur if the number of organisms in the specimen is below that analytical sensitivity of the test, and a false positive can occur if there's not appropriate care taken to preserve the purity of the materials itself. So mention false positives and false negatives. Some other reasons for potential false negatives would be the presence of new or unknown MRSA variants, unable to be detected by the assay, or it could possibly be because interference of substances such as blood or nasal secretions in the nasal cavity. Something else that's important, a positive result does not necessarily mean that the organism is viable. It is just a direct measurement of the presence of DNA. So could still be present even if the MRSA inhabitants are no longer living. Something else to know is that once tested, and if the result is positive, and then a subsequent test indicates a negative result, this could indicate eradication, but this could also be due to anti-MRSA treatment or just natural riddance of that MRSA or intermittent shedding. So 2 main purposes of screening: infection prevention and control, and my favorite, antimicrobial stewardship. But we'll first start by talking about the infection control portion of why this screening is done. So MRSA is considered what the CDC regards as an epidemiologically important organism. So according to the 2007 guideline for isolation precautions, what these bullets basically are saying is that MRSA is readily transmissible. It has a tendency to cause outbreaks. It could be associated with a severe outcome, or it could be difficult to treat. So this is what makes it an epidemiologically important organism. The presence of MRSA colonization does necessitate contact precautions, both direct and indirect. So clothing, uniforms, laboratory coats, isolation gowns used as personal protective equipment or PPE could become contaminated with that potential pathogen after caring for a patient who's colonized or infected with an infectious agent. So this could be considered indirect contact. And then person-to-person transmission is also possible. Healthcare workers, hospital roommates, this would be considered direct contact. So because of this, there is, in addition to standard precautions, extra emphasis on proper hand hygiene, gloving and degloving, etc., strictly enforced by infection control in the hospital. In some cases, cohorting, especially when outbreaks are of concern, is possible as a mechanism to prevent spread. Airborne precautions are often in place if the infection is respiratory. And if a patient's colonized, depending on the unit, there are certain decolonization procedures such as the use of intranasal mupirocin or chlorhexidine baths. All right, so now moving on to the antimicrobial stewardship part. This is a little bit of an overwhelming slide, but essentially these are different IDSA guidelines for different sorts of infections, starting with pneumonia on the top, all the way down to surgical site infections, diabetic foot infections. But what I just wanted to demonstrate here is that unfortunately the vast majority of these guidelines for the treatment of these infections do have some sort of recommendation for addition of anti-MRSA therapy. So given the wide variety of infections that can be caused by MRSA, in addition to recognizing patient risk factors and also the fear of the potential morbidity and mortality, it's not surprising that anti-MRSA therapy is used empirically as frequently as it is. And as you can see, there are, as mentioned, these recommendations for addition of coverage, but what is lacking in recent guidelines is how to de-escalate prior to culture results being available. So now this is where some important terms come into play when it comes to utilizing the MRSA-NAIRS test to guide clinical decision-making. So we have to understand how to evaluate and interpret this diagnostic test by understanding the terms bolded here. Now, earlier I mentioned that the PCR has a sensitivity of 92% compared to an 86.9% sensitivity in cultures. What this means is that the MRSA-NAIRS PCR has a 92.5% probability of detecting that MRSA DNA when it is actually present within the NAIRS. Specificity, on the other hand, is defined as the probability of the test being negative when the disease or the colonization is actually absent. So therefore, an example we can say is an assay with a 100% specificity. If we use that and results are negative, we can be 100% certain that there is no MRSA DNA present. No chance of a false negative. These two terms are often used interchangeably with PPV and NPV, the predictive values, when their definitions do differ pretty significantly. PPV is defined as the probability of the patient actually having the disease when the test to detect it is positive, while the NPV is defined as the probability of the patient not having the disease when the test is negative. So it can be a little confusing, and it's no surprise that these terms are kind of used interchangeably, but a way to think about these terms in a way that might help differentiate appropriateness of use is that a predictive value is more often useful for a patient when they're able to assess how likely it is that they have a disease, depending on the testing results, where sensitivity and specificity are more useful, in my opinion, for clinicians when deciding what test to use to accurately diagnose that patient. So if that wasn't exactly clear, no worries, it is confusing, but we can walk through a generic example here. And I'm just checking to make sure formatting looks good and nothing's crunched. So as you can see, the table on the screen here, the columns correlate with the presence or absence of disease, and the rows here correlate with the test being negative or positive. So we can say that this is our MRSA-NAIRS, and this is whether the patient has a MRSA infection or not. So if the disease is present and the test is positive, this would be a true positive. And for the purpose of understanding how to calculate this, I've labeled this with variable A. If the disease is absent, but the test results positive, this is a false positive, designated as variable B. If the disease is present, but the test results are negative, this would be a false negative. And if the disease is absent and the test results are negative, this is going to be a true negative. So to calculate the sensitivity, we would take the number of true positives, divide by the sum of true positives and false negatives, and this would give our percentage of true negatives, or sorry, true positives. See how this can be confusing. And then to calculate specificity, we would take our true negatives and divide that by the sum of our false positives and true negatives. Now on the flip side, to calculate the PPV, well, I won't go through the formulas here, but essentially taking true positives and then dividing by true positive over, sorry, let me start over. PPV, true positives over the sum of true positives plus false positives. So you can see how this can differ from sensitivity, and so on and so forth with NPV. One thing that I did want to point out, though, that that separates the predictive values and sensitivity and specificity is that the predictive values are directly related to the prevalence of the disease. So for any given predicted value test, as the prevalence will decrease, the PPV will decrease. And in a similar manner, when the prevalence decreases, the NPV will increase. So a quick learning activity for the sake of time, and I'm sure no one wants to do math at 6:30 p.m. But here is just an example. So if we were to take some, let's say this is a data table from research that we've collected within the hospital, and we've aligned our true positives and negatives, our false positives and negatives, and we want to calculate the negative predictive value of MRSA screening to predict the presence of skin and soft tissue infections, for example. We would see here that our answer is 93.5%. So this would be our negative predictive value based on the numbers in our table and our math problem as previously displayed. So now that we know how to interpret these diagnostic tests and calculate the values, we can dive into some real world applications in literature. There have been a number of studies and meta-analyses that have been conducted to analyze the predictive values of MRSA colonization to predict pneumonia. Overall, findings have been pretty consistent and with high negative predictive values as high as 95 to 100%. So these results suggest that in the absence of MRSA detection via the NAIR swab, this can be used to our advantage as an antimicrobial stewardship tool to either completely avoid the addition of anti-MRSA therapy or to even de-escalate. So something else I wanted to say too, avoidance of anti-MRSA therapy. So this could save a patient from experiencing related side effects. So not any medication is benign. With vancomycin, for example, we can see infusion reactions, nephrotoxicity, and a few other side effects that are not very pleasant for the patient. But also furthermore, the costs associated with vancomycin use. And I'm just using vancomycin. There are many anti-MRSA agents, but the one most frequently used in the hospital. The costs are not limited to the drug acquisition itself, because that's typically only about anywhere from $15 to $50 in a day, but pharmacokinetic management, laboratory costs, nursing resources, all of these can add up to about $300 a day. So this is just an evidence table here to demonstrate that, yes, we're aware of what we've learned from our use of MRSA NAIRS PCRs in reducing or avoiding MRSA therapy in the case of pulmonary infections. So we can see studies with sample sizes as high as 40,000 and a few meta-analyses, all with really high, consistently high negative predictive value. So up to 98%, even as low, but still a very high number, almost 95%. But again, going back to that point I made with prevalence, we can see as the prevalence of the disease is low, the negative predictive value is high. So even in these pulmonary infections where the prevalence is very high, we still consistently see a really low negative predictive value. So we would be at the least 95% sure that this patient doesn't have a MRSA pneumonia if the NAIRS is negative. So that is something that we've all agreed upon in clinical practice. That is generally something that if we recommend based on the results to de-escalate clinicians, specifically doctors who are, dictating the orders, they will necessarily listen to our recommendations. It's very widely accepted, but we're going to go through some literature to show that that concept is not just limited to pneumonia. So this is a study titled Prediction of Methicillin-Resistant Staph aureus Involvement in Disease Sites by Concomitant Nasal Sampling. And this was a retrospective cohort study. This was conducted at a large metropolitan academic center. It was conducted in attempts to examine whether MRSA nasal colonization predicts MRSA-positive infections in sites other than just the respiratory tract. So over the 2-year period, there were about 5,700 cases of nasal PCRs collected within a 24-hour time frame of a clinical culture also being collected. And of these cases, 323 had MRSA in their MRSA infection, and out of these cases, about 200 had a positive MRSA NAIRS PCR. But of important note, this is across the cultures were taken from sites from the bloodstream, skin and soft tissue infections, ulcers, respiratory tract, and urine. And these are some results displayed here, table 1, illustrating the number of patients who had a positive or negative MRSA test and the patients who actually tested positive for MRSA. So just given these values, we can, if we wanted to, do the math and actually calculate those negative and positive predictive values. But this study did actually report that for us, thankfully. But just to show here, we can see the different MRSA culture sites. And of course, we see our respiratory section here and our negative predictive value, as we would expect, about 98%. But even skin and soft tissues taken from the extremities, those cultures, bloodstreams, these all have really, really, I would say, high negative predictive values, even about even 89% in ulcers, for example. So this study basically shows that it's not just limited to pneumonia. Specifically, the study highlighted the fact that the prevalence of disease in all of these infections was low, so less than or equal to 10%. So if one were to conduct a study in an institution and drawing conclusions from that, it would be important to calculate that prevalence to determine if these results can be extrapolated to your own practice or institution. And something else to note too, when we're reviewing literature, strengths and weaknesses, limitations of this one. For example, we didn't know the patient demographics, mentions of risk factors. So who out of these patients actually had some of those risks that we had described before. And in reality, it's very rare that we collect cultures and PCRs that close together. If we did, it would be great, but that was the case in this study. They were all collected within 24 hours. All right, so that's one. We'll go through one more pretty strong piece of literature. And this one is titled Determining the Utility of MRSA Near Screening and Antimicrobial Stewardship. And this was a retrospective cohort study of veterans with data collected from 121 VA facilities with the intention of determining the NPV of MRSA colonization screening and the determination of subsequent clinical cultures for MRSA. So pretty much virtually identical to what we just reviewed in the past study. So as I mentioned before, it was mandated, I think it was 2016 or 2017, that every patient admitted or transferred to a VA facility had to have that MRSA screening. So looking at this retrospective study, this was a pretty large N. About 500,000 clinical cultures within this study were evaluated. And this again is a busy slide, but just wanted to again highlight this is the entire cohort. So including all of these separate infections, whether it be blood, pulmonary, intra-abdominal. When we are talking about all of those as a whole, we're still seeing a really high negative predictive value, about 96.5%. And these are all statistically significantly calculated. Of course, we see with our pulmonary, what's nice about this study is that they separated out between whether the culture was sterile, whether it was a BAL versus sputum, for example, but still consistently seeing these high NPVs. We see urine, we see wound, we see different kinds of wounds. And since the prevalence of MRSA in a skin and soft tissue infection is higher than what we would see in, say, a urinary tract infection, we do expect to see those lower NPVs. But still, in my opinion, I would still argue that a 93.5 example NPV is worth arguing to de-escalate therapy for if we see a negative MRSA NAIRS. Even cultures from the eye, ear, nose, and throat, central nervous system. So pretty consistent with what we've learned from cases of pneumonia. So as a result of this study, the author concluded that a negative MRSA swab taken within 7 days of the culture is useful for predicting the absence of MRSA in a subsequent clinical culture, referring to the entire cohort with all of those infections we saw. Some strengths and limitations are listed here. As we mentioned, large sample size, variety of infections. One thing we have to keep in mind when evaluating literature too is the methods of collection. So in this case, they included both nasal culture and PCR. It was mentioned that in both cases, the NPV was still within the 90th percentile, but something important to make note of when extrapolating results again. So, which is common in some of these older studies where culture was a little bit more frequently used. And I won't go in depth to any more studies, but those two I wanted to just demonstrate because they were all inclusive of all different types of infections. But here's some additional evidence for bloodstream infections. And just wanted to point out, we see VAs, we see tertiary care hospitals, including critically ill patients, medical patients, large sample sizes. So bloodstream infections, we still see pretty high NPV. Again, have to see whether the prevalence is reported and take that into consideration as well. Intra-abdominal infections, most of these patients are in the ICU. As we can imagine, an intra-abdominal infection with MRSA is pretty rare, so the prevalence is likely low. But in cases where it was high, which we could anticipate from a hospital-acquired infection, we would still see a high negative predictive value in these sorts of infections. In skin and soft tissue infections, there's a lot of emphasis on this now. So at my institution, we're initiating a study or trying to get it rolling, looking at diabetic foot infections, because you see a diabetic foot infection, automatically they're on vancomycin and Zosyn, or vancomycin and cefepime flagyl. But that just because you see a diagnosis should not necessarily mean that you tie an empiric therapy to it, unless if you have evidence to do so. But in cases like this, we see, again, negative predictive values of up to 97.5%. But what makes this a little bit more of a touchy subject is that depending on the prevalence, sometimes the range can be pretty wide in the case of this example. And we see a wide range of negative predictive values. So in my opinion, when evaluating predictive values with skin and soft tissue infections, I think it's very population dependent and hospital dependent. So curious to see what our institution would result. And lastly, urinary tract infections, not very common, high negative predictive value. Basically all I wanted to say there. So just to highlight some of the important roles of the pharmacist. Of course, I'm a pharmacist, so I love to have purpose with my recommendations and using my knowledge to hopefully make some positive initiatives and efforts for future practice, whether it's appropriately incorporating the screening into clinical practice with other types of infections aside from pneumonia, assisting with education or interpreting the MRSA PCR results as we're doing today. As I mentioned, conducting or guiding research to evaluate local trends. We can also have influence on institutional guidelines with new evidence that's coming out, and then advocating for new protocols or system level implementations that can allow us to make clinical decisions. So for example, at UF, we have within our protocols, if we see a patient that has a pulmonary infection and they don't have a MRSA, we can go ahead and order it per protocol. Technically, we should not do that. It's outside of the protocol to order MRSA for any other indication. But if we have enough evidence, this is something that we can advocate change for. Looking forward, there are a lot of potential opportunities to further promote antimicrobial stewardship within this area. As we have seen, the PCR is a useful tool, but it might not be used to its fullest potential today. Outside of the nasal PCR, it's possible to screen other sites and other anatomical sites that pathogenically might make more sense, particularly with skin and soft tissue infections. Evaluating a swab of that particular area and correlating that with an actual culture. Also, if we utilize multiple sites, so if we take a swab of the nares, if we take a swab from the groin, for example, and they're both positive or they're both negative, that could enhance our predictive values. So that's something to think about. And of course, more research. That is something always to look forward to and to see with our study what we can identify and how we can make change going forward. Okay. With that, I'm happy to answer any questions. And I thank you all for your time.